I appreciate it. Welcome, everybody. Thank you for joining us today. I'm Melissa Martin. I am employed by the Wyoming Institute of Population Health. That is a branch of the Cheyenne Regional Medical Center. I'm based out of Cheyenne, Wyoming. And if you understand your geography, you know that we sit, well, first of all, Wyoming is a square state. We're one of the 2 square states. And we sit in the bottom. We're in the southeast quadrant or corner of the state. It is about 20 miles to Colorado border, and then if you go the other way, let's see, I can get there in probably about an hour to the Nebraska border. So we sit right in the bottom of the state. I tell you this is important to understand that while we are the capital of the state, Cheyenne does have the capital, the rest of the state doesn't always think that we are a part of Wyoming. So Wyoming is about 60,000 people. We are the biggest city in the state. So if you just think about that a minute, compared to wherever you are in the nation, 60,000 people is not a lot compared to some of the other cities. I can get to Denver in about an hour and a half to 2 hours, depending on traffic. If we want a metropolitan area, we go there. But the whole rest of the state of the Wyoming is very rural. There are 2 other things that I want to tell you about this process and what we're going through. That's a big one. We are rural. In fact, the government designation for rural doesn't necessarily fit us. I think it's us in Alaska, maybe Montana as well. Correct me if I'm wrong, but we are more rural than rural by the government classification. We are called frontier. So we have the frontier classification, which means there's a lot of room and not very many people. And we are the least populated state in the nation, and that brings us a lot of pride. If you're a Wyomingite, you know that we kind of pride ourselves on that, like, haha, there's not very many of us. But then we're also a little distrustful and a little resentful that we don't have the population to maybe make as big of an impact on a national scale as maybe that we would like to. So that's kind of a dual mentality we have. We celebrate it and then we kind of loathe it at the same time. So I grew up, well, I graduated from high school here, moved away, and then came back, as common with our youth. They run away and then realize they liked Wyoming after all, and then they come back. My kids are in the process of doing the same thing. And oh, I had a thought, but now it vanished. I graduated from high school here as a military kid, so I bounced all around, but I do consider Wyoming my home. My immediate family, my mom, my sister, and kids and whatever are still here, and so that's great. But do have some experiences in other parts of the country. The 2 things I wanted to tell you before we really get rolling on this, definitely the rural mentality comes into play. And those of you that live in rural areas understand that we're a pretty independent bunch, and we learn to do things by ourselves. We're not Wyomingite. I can't speak for other rural communities, but Wyomingites don't often share. There's a lot of pride and a lot of identity into being able to solving things by yourself. That's that pull yourself up by your bootstraps mentality. We will share, we will talk with family members, but even then, it really depends on your socioeconomic status and where you are and how much trust. I, as a military kid, moved here, then came back. I'm still kind of considered a newcomer because that lineage of being in the area and what land does your family own still influences decisions that are made and who you network with and who you are a part of, which I also find interesting. It's not only distance that is a barrier. We serve I was going to look it up, but Wyoming is a big state. I don't have the numbers right away. So with healthcare and with services, it's not distance that's a barrier necessary. We think nothing of driving an hour to go to dinner and then coming back, and it is not through traffic. It is like to another county. One of the places, as a side note, one of the places I lived in when I moved to upstate New York, I was working for an organization, and I would schedule workshops and trainings and meetings, and the thought was, well, I can't go over there. That's in the other county. And in my Wyoming brain at the time, I was like, but that's only 15 minutes away. What's the matter? Oh no, that's crossing a mental hurdle. In the East Coast was apparently a thing that I had to learn. I had to schedule it in their own community. We don't, in Wyoming, don't have any problems with running all over the place, and distance is measured that way. However, it is the attitude that's a barrier. We are, I just looked it up, number 3 right now, ranked in suicide. Montana is currently number 1, was of 2018 figures that I saw. Excuse me, Alaska is number 2, and Wyoming's number 3. The 3 states swap those back and forth. At times we've been number 1. Montana, Alaska has been really high in suicide, and it's not necessarily all the angsty teens that we're worried about, although that is a concern about suicide prevention. But our suicide prevention team focuses on pretty much our rural ranchers, our men that are so strong and so stubborn, I will say, that will not reach out when in times of trouble. That will give you a sense of the attitude of our rural mentality. We're also a conservative state, so we services are also kind of looked sideways upon, and that's going to come into effect with the next point I wanted to make about Wyoming. So I work for the hospital in that southeast quadrant, but the Wyoming Institute of Population Health serves the whole state. I was brought on board, and I'll move to the next slide. Oops, there it goes. Yep, I'll use my mouse. Okay, there we go. I began working with Enroll Wyoming, and it's a part of, it rolls up under the Wyoming Institute of Population Health. We were brought on to work with the Marketplace Navigator grant, and so we achieved the grant, or received the grant, and then we were tasked to travel all over the state, educate people on the importance of having health insurance. Not sales, education. And my staff was great at educating people, but can you imagine, based on the comment I just talked about being very private, conservative, and a little distrustful of different services that are offered, that it was not very well received. Our team really thought that maybe they were, we'd send them out in safety in numbers. We send them to these old rural areas. One of the experiences they had is they went to a community, a small community in the western part of the state, and was told that when they came back, they should probably wear camo and they might fit in better. And they thought, why? So you can't see us? So what's going on? But, you know, it was that kind of mentality, like, we're going to listen to you, but we really don't know. The other example that I found humorous was that these, you know, very stern Wyomingites would sit there with their growly faces on and listen to what was going on. And they said, well, I don't need that Obamacare. But tell me about health insurance. Like, how can I take care of my family? So it was almost under their breath that they were very stern about, they didn't want Obamacare because that was the thing. But they might be interested in some health insurance. Tell me about the marketplace. I'm not realizing that that's the same thing. So that was interesting, is the terminology kind of changed. The crew would not, or the people they were serving, they didn't really want to talk about their health, but they might, you know, say, well, my child needs this, or my child needs this. So that protection mentality came into play. When it comes to health insurance, and we've seen this in our hospital as well, the poor are judged not for asking, not only just for asking about services, accepting assistance or whatever, but for using it. So you can see, as we're looking at the Bridges model, and the choices that people make, there's a real hesitancy to reach out and use the services, not only just for asking about it, but then actually using it. You will see on this next slide that, did I cover everything on that one? You'll see on this next slide that this is Cheyenne Regional Medical Center's aim in order to providing services to our community. So we want the best health, the best care, and the best workforce for the best value. And our goal really is to reach out and to serve people, which is why I like working for the Institute of Population Health, because then it does wrap services around. It's not just about healthcare physically, but then how do those services come back? The next part I want to tell you, so as we move into this 4-part story, which is the organizational method that we're going to talk about what was going on, you will see that, I'm guessing it was like 20, 30 years ago that and I've heard rumors, I did not experience this myself, but I heard rumors that the billing department had few standards for evaluating late payments or missed bills or whatever. They would determine your eligibility very subjectively for assistance, such as they'd look up what zip code you had. We have probably 4, I guess, in Cheyenne, and which zip code told you which part of town that you were living in. And so like, oh, were they living on this side of town, then maybe they should pay this much. Or they would know what kind of car you're driving, or they would look up your family status or influence in the community and thought, oh, well, they're a part of so-and-so, so they should be able to pay this. And I can imagine the horrified looks on your faces, just like when I heard this, how awful that is. But it was very much the biases on the staff, it's assumption before they even met the consumer, coming in order to make their hospital payments. That's what was happening prior to me coming on board. So when we received the grant and then we came in to evaluate what's going on, let me move to the next slide. My supervisor, who had been through the Bridges Out of Poverty training, really appreciated the kind of empathy. She also grew up in Wyoming and understood the Wyoming attitude, and this helped her shift beyond that. She said that Bridges Out of Poverty made her better at customer service and a better supervisor because she could meet people where they were at and coach them where she needed to be, where she needed them to be. Really opened her eyes to the importance of how do you respect the person. Instead, some of these implicit biases that she didn't even know she had because of where she lived, and environment plays a big part of that. She then sent me to Bridges Out of Poverty training, and then I trained our marketplace navigators, and then have continued to educate people around the community. She has modeled her change, and now she is seen, as you can tell in the slide, her staff is now holding each other accountable and then working better with one another. These little tweaks that they are making is having huge impacts on how our work is carried out. One of the examples is when I was working with one of the teams, what I was finding was a lot of our frontline staff was bringing in this perception, of course, for wherever they grew up or whatever information they were getting before they joined the hospital. And our frontline staff, some of them coming from places of poverty. And I thought, okay, good, they'll get it. They'll understand that they don't do this alone, and that they need to treat people with respect. Of course, that's what they would want. And what I found is that a lot of them were very judgmental and distrustful of other people in poverty or living in instability. And when we reflected upon this, excuse me, we realized that they were moving out of poverty. Hooray. But they forgot to remember how important it was that they did not do it alone. That they thought, well, I pulled myself up by my bootstraps, so can they. And they almost were wanting to keep people where they were so that they could feel better. And of course, it wasn't everybody, and of course, it's an overgeneralization, but I thought that was an interesting trend to look at how people even if you think that they should have empathy, or maybe lacking that empathy based on their own lens of understanding. So we have now acknowledge this, that we did need to change some of the attitudes and some of the understandings within the hospital and then around the state. And I'll come back around to those navigators that are traveling the state in a minute. So what we have done is the Institute of Population Health reaches out to agencies across the state, and we want to educate them not only on the rural ideology, but then what are some of the key principles that AHA process celebrates. So what are those driving forces? How are they make decisions? I went to a community north of here, and I worked with a team that mainly serves children from primarily low-income families. This director had been exposed to Bridges Out of Poverty, and she ran all 90 of her employees through Bridges, the 2-day Bridges workshop, and it was phenomenal. Everybody from their CFO to their bus drivers to their teachers, everybody needed to go through this, and it was mandatory. It was a part of their in-service. I met with the person later, and after only 6 months of this initial awareness building, the director reached out to me and said that she has seen a lot more empathy and a lot more problem solving with families than she had in the past. And so there's a couple of reasons why I think that happened. I think what it did is it gave that staff permission to think differently about their culture. So they're in a different community than I am in Cheyenne, and I don't know all of the information or perceptions that they have in that community, but what I saw happening was that they shift the paradigm. Like, you know, in the community, I know you have your way of thinking and I know you have your understanding, but here at work, this is what we expect. And it gave them permission to think differently about their population. And then what happened is they started holding each other accountable. As you can imagine, or as you know, there's a lot of information in that 2-day training. And what one person remembers, the other person might need a reminder of. And so they continue to have those conversations, and we're able to treat the consumers they were working with respect and help them move into, okay, but let's talk about what we need here. It wasn't about excusing the choices that people were making, but it was about meeting them where they're at and then coaching them where they needed to be. This resulted, you can see in that last bullet point, that she sees her staff holding each other accountable for their actions and be more proactive rather than, well, we're not going to talk about it. We're just going to give them the side eye, and then we're going to just, you know, kind of, I don't want to say patronize, but, you know, just kind of understand, well, I guess that's who they are and that's their family status. So we're just going to go with that. But how can we begin to elevate and work with people? Which then I got all giddy and was like, yeah, go you. So it's a good thing. So the next slide talks about what it's like now. So what are the outcomes? What are the results? And as I've alluded to, is that treating people with respect is huge. Not only our customers, our consumers, our patients, our clients, whatever label you want to put on them, but also internally, like how do we coach each other and help? The understanding that nobody achieves this alone is probably the biggest takeaway that I've seen. How can we work within the communities in order to identify all of those resources that are outlined in the Bridges Out of Poverty model? That's a huge shift and very counter, as I started with, to the Wyoming mentality, where yeah, you are alone, and there's a lot of pride in being able to be self-sufficient and do it yourself. But there's a lot going on in our culture, and we need to be able to reach out and work together. It is beyond money, and it is beyond health. And I've seen that attitude shift. It is not just about your socioeconomic status in dollars, but it is about reaching out to build in those other resources. Let me tell you that the navigators are still going strong, and you can imagine in our political climate with the ups and downs that have been going on with funding, and we are grant funded, and so that's always a dicey place to be when the administration changes, but I will tell you that we have moved out. We are still serving the state, which is phenomenal, but the hospital in Cheyenne Regional Medical Center, has now taken and embedded this process of education to within their own walls. Okay, so let me describe that because I kind of fumbled through that. Thanks for bearing with me. So the Institute of Population Health served Cheyenne Regional and the rest of the state. So while they are still doing that, and rural Wyoming is still doing that, now what has happened is some of those navigators are now employed directly by the hospital, have an office in the hospital, are working closely with those financial oh, I just dropped their name. The people that work with the financial payment plan within the hospital, they're working so close with them that a lot of that education process is coming through. I hope that's clear. We have repeat customers. So we have people that we've established a relationship with 1 year or maybe 3 years ago, reaching back out to us saying, oh, I had a life change. I'm getting a new job. Tell me what I need to do about my health insurance. And to have them seek us out is phenomenal in a culture that does not celebrate and promote that. You can imagine that in some of our rural areas, we would have volunteers help us in those areas. And it was great. They were part of a clinic. They were passionate. They were on fire, and they were serving their little corner of Wyoming, which was great. But there's a high turnover. And as soon as that person moved to another agency, moved to another job, then we'd have to reinvent the wheel. We'd take that, that wonderful, passionate employee, and then we'd have to regroup and keep going. So what we're doing now, or what we have always done, is how do we embed that knowledge beyond the person? I would say that's still a challenge in our area because we do see some high turnover in some of those smaller communities of reaching those consumers. What we have done is partnered with Wyoming 211. And as you know, 211 is a service. Many states have a 211 call center, and anybody who calls 211 will get funneled through to reach and find a health insurance navigator to help them work through these issues. With a small staff, we can't be everywhere, and we have found that partnership with Wyoming 211 to be huge. I want to end my part, and then I want to open it up for questions by just wrapping up and saying that every year that Enroll Wyoming has been in existence since the beginning of the Marketplace Navigator Grant Award, since we received the award in its inception, 2014, I believe. We have increased the number of insured individuals in Wyoming. And with all of those barriers that I told you about in the very beginning, we are very happy with that. And we're very pleased that we can keep growing the number of people who have access to health insurance. And we continue to be grant funded. We are getting ready to submit our grant for the following year, coming up with 2019 and 2020. We are creating a model of collaboration throughout the state. So we are modeling that we are not doing it alone. And I think that's also kudos to my supervisor who had that brilliant idea to be able to break down some of those cross-agency barriers. We need to reach out and work together. So we are partnering with Wyoming 211. We're partnering with other hospitals. We are partnering with other agencies that serve people rather than competing for funding and resources. I did tell you already that Cheyenne Regional, our local hospital, has incorporated this work into their own business model and employ a staff to conduct similar work, and that is huge. Eventually, my goal is to work ourselves out of a job and have this model already embedded throughout the state. All of the staff at Cheyenne Regional have been exposed to the 2-hour training Bridges workshop, and then we are looking to offer longer trainings so that we can keep moving forward through educating people that are coming on, including our onboarding process. Now, where we are at the moment is that we are exploring new ways to provide this year-long customer service training. What we want to do is we're finding that, as I mentioned earlier, that even the 2-day workshop, there's so much great information that if we could space that out, give them some tools, have them go back to the work, apply their work and apply those tools, come back again, let's talk about the next set, and then keep going. We're finding that's where we want to go next, is see if we can maybe embed this knowledge even further. So I will wrap up there. Thank you for listening to me ramble through my 4-part story and joining in today. And we will open it up now to questions. And I have the chat bar open. And if anybody wants to ask any questions, that would be great. Or you can share an example of how you've seen this work in your rural community. Would be also helpful for me. Does anybody have a scenario or a situation similar to where you have seen this shift in attitude? I'm especially interested in anybody who's seen where you can meet people where they're at and coach them where they need to be. I'm fascinated by that kind of process. Thank you, Peggy, for your comment. Yes, that collaboration, I think, is huge. That transparency, it used to be we fought for funding, and I see some of that attitude kind of breaking down. I can't do what DFS does, and they're in families' homes, but if I can partner with them and I can empower them to understand what we're going through, that's another tool in their toolbox as well as another tool in our toolbox. And we have seen that be extremely successful in order to wrap in services around the consumer so that all parts of that person's needs are met. We can't do it alone. So I appreciate that comment. Anybody else have comments or questions? Does anybody else have a 211 agency that they're working with? And I really recommend that's been the stable for us in order to be able to reach out and include, you know, when I was talking about how agencies, that Spitfire employee comes and goes, that's the base. And when you're grant funded, it's extremely important for us. So the 211 staff is also trained as marketplace navigators, and they can answer questions. Oftentimes they will answer the questions that are softball questions, because you know they're running in all different fields. And then if they need extra support and extra help, then they partner with us, or they do a warm handoff and say, let me introduce you to so-and-so who's a navigator and can answer some of those deep dive questions. Early on in the grant period, we got what we called the low-hanging fruit. So it was all those softball questions, and mainly it was just about educating people and getting that buy-in on obtaining health insurance. What we're seeing now is a lot more complicated issues, such as, well, I'm divorced and my spouse has our child 6 months and I have our child 6 months, and how do we split the health insurance, and how, so some of those deep dive type questions, or I'm retiring, and what do I do with my disabled son? And so those are the kind of questions that our team handles. In Wyoming 211, we partner back and forth so they can be able to have input as well. Any other suggestions or comments?
Is your Institute of Population Health federally funded?
It is funded by Cheyenne Regional Medical Center. And I apologize, I can't tell you any more than that. I am not in that part of the world. I don't know the administrative part of the Institute of Population Health. Another one.
Amanda wants to know, are there other states with frontier designation?
I would say Alaska as well, and I'm not sure beyond that. I'd have to go back and look that up. Like I said earlier,
okay, and Debbie,
maybe Montana.
Yeah, okay. Debbie wants to know, how do you get the attitude shift change around competing for funds?
You know, that's a great question, and that did not come easily, and it really was a lot of relationship building between us and the director of that agency. And what we did is be able to build that relationship and let them understand that we are not vying for funding, that we are wanting to help and provide information to them. One of the agencies we work with is the Kid Care Chip program in Wyoming, and we would invite them to come table with us. And so by offering that olive branch, essentially, like, come here, come work with us, and then we can work side by side. You can help talk to the kids, and we can help talk to the parents about the kids. And so when we would do tabling events, we would encourage people to come to the table with us. Sometimes we would invite them for free. So to have a table at this event was $150. We would do that and pay for that and built that into our budget and say, if you want to come, bring your materials and be with us. That was the one way that we could break down some of those barriers, tangible ways that we could do that. We were not competing the market for reaching those people. We were adding on other services as one of the ways we did that. Great question. Thank you.
Aaron says it sounds as if you have healthy participation with 211 from agencies. Here in our area of Nebraska, our organizations are not. When we put in our zip codes, we get resources from Omaha and Iowa, 2 hours away.
Mm-hmm. Yeah, and I will tell you that 211 is stronger in some counties around. We have 23 counties in the state, and 211 is stronger in some counties than others. 211 strength is to have that partnership with those agencies, and just like I was talking about before, sometimes that partnership doesn't come smoothly or easily. When we've traveled around the state, we're like, just call 211 is our standard mantra, and people have said at times that, well, I did, and they didn't have anything in my area. So 211 has been in existence probably a year or two longer than us. Could be longer, I'm not sure, but they are continually trying to build their database. And when we came on board, they were thrilled because we became their boots on the ground, and we ran around and helped advertise 211 and would talk to agencies when we were visiting with them and say, you need to get on this list because this could be further outreach. So that we were able to promote each other, which was a benefit that we had. But I do understand and respect your struggle because, yeah, that is a tenuous. And if you have somebody that's involved, a good agency that's a part of 211, then it keeps going. But a shift and change happens with personnel, sometimes that might get dropped. So I applaud you for keeping going and helping this great resource. Thank you for your thoughts in that question.
As a follow-up to that, she wants to know, how did you get buy-in for groups to participate?
How did I get buy-in?
Uh-huh.
Say that again, Leonard. Buy-in for?
How did you get buy-in for groups to participate?
Different agencies, I'm guessing you're meaning, to participate and to partner with us. It wasn't always easy, especially in the beginning, and that distrust of Obamacare, and they didn't want to have anything to do with it. Once it was, again, back to relationship building and really focusing on the education part, and why that education was necessary. Once they figured out we weren't working on commission, like some insurance agents do, that came a little bit easier. It was us being very transparent about what we needed in order to get them on board. I will tell you that some of the smaller agencies came a little bit easier because we are another resource and support for them. And when they're lacking funding and staff, you know, that was helpful. We could come in and help with it. We did some baby showers, community baby showers, and we were another resource to give women in order to provide for their children. And so it was like, sure, come on board. Where we saw some challenges was some of the larger entities, like other hospitals. As soon as they saw the Institute of Population Health name, they were okay. But then if they saw we were based out of Cheyenne, then they became a little bit distrustful. The rest of the state thinks that Cheyenne might as well be Colorado. We are close to Colorado in proximity, and we're big. Like, we don't even understand what it's like to live in Wyoming because we have 60,000 people. And I get that. You know, there's some of our communities we're serving have 50 people in their communities. And so we do feel like a big community. But it's some of those other agencies, those larger agencies and other hospitals that didn't want to be associated with. So to embed this process in that hospital, there's still that little bit of political maneuvering, I will call it, that even though it is good for their consumer, they really want to do it themselves. So we're still working through that process. Oftentimes we would find somebody who worked directly with consumers. We're like, oh yes, we need this. But then they would need to convince the hospital administrators in order to do that. And so then we started doing both. Like, let's get somebody that is working directly with the consumers on board, and then let's go talk to the hospital administrators and say, this is why this is important. Set aside that we are in Cheyenne and talk about what's good for your consumers and get the administrators on board. And that had moderate success. In one of our communities, we got buy-in from one of the administrators, and they're like, oh yes, we need to do this, and tasked a department in order to be able to educate people. That went fairly well until that person then shifted out of that role, or at the end of the year, it was the end of the year and they had new goals, and then suddenly we weren't a priority anymore. So that kind of struggle is still going back and maintaining those relationships, which is work. True. Good question. Thank you. Any others, Leonard? Oops, excuse me.
We don't have any right now.
Okay.
Any more questions from anybody? Go ahead and type them in and I'll send them to Melissa.
And thank you again for your patience, everybody. So if there aren't any more questions, I believe my contact information is somewhere, and I welcome any great ideas you have and any ways that you are using the Bridges Out of Poverty model in order to supplement your own work. We found that attitudes around health and health insurance are something, but then how do we really reach people living in instability or living in poverty, and why they don't always go hand in hand. What we found is it really was able to give us a framework of understanding to foster that respect that we needed to build those relationships in order to get our information and our knowledge out there. If you can meet people with where they are and treat them with respect, that will go a long way. The other key thing that I thought was valuable was it's one thing to send one person this knowledge and to say, okay, you got it, go. But to really change a culture, you need many people to work through this process. Like I said earlier, it's one person remembering this key point and another person remembering this key point, and having those conversations in real time in real life in order to be able to focus and to shift the paradigm in the workplace. Even more importantly, I apologize. Even more importantly, to be able to counteract maybe some of the outside influences that are coming in our community. You know, where there's some pretty stern and some pretty deep-seated cultural biases, and this was able to set those aside when you come to work, and let's do this. It is a journey. It's not a one hit and done. It is a process, which is where we're going now. Is how do we then be able to keep working with people in order to layer on those experiences. So I really appreciate you taking the time to listen to me today, and hopefully some of this hands-on information was good for you, stuff that we have experienced in Wyoming. Great state to be in. Every state has their challenges and ups and downs, as you can imagine. We enjoy living here, and we love the people that we serve, and we're really trying to serve them in the best way that meets their needs. Leonard, any other questions? If not, I think...
Yes, we have one more before you
Okay.
go. Jennifer says, could you share more about the importance of relationship building with individuals and families in poverty, and how building relationships is essential to moving them to independence?
Yeah, great question. Thank you for asking that. One of the things that was very key, and I lightly dusted over it when I started, is that we went all over the state. And that is huge when it comes to establishing relationships and building trust. I'll give you two examples. One is that we have an office, but we did not expect our staff to be in that office. That was a touch point, and then we sent them out in order to be where the people are. Essentially, that just almost sounded like a musical, but that's not where I was going. It was wherever they were at, we went to them. So if they were having a resource fair, one of the examples is we had mines closing. If you can remember, when coal mines started shutting down in Wyoming, if you heard that in the news. But in the Wyoming, it's within the last 5 years. And we had huge impact on communities whose main income were the coal mines. And so we got wind of that through Workforce Services, says this is what's going on. So we partnered with Workforce Services. We went into the communities, met with their HR departments, met with the people there, rather than handing out a flyer or putting up a PSA in some fashion and saying, call us if you have questions. Oh no, our faces were in that community. We'd stay there for a period of time, and we'd be able to talk and work with people. So wherever they were, we were there as well. And that was big. Our travel budget is huge because it is so important to be face-to-face with people at the moment they need us. The other example I have is we also have a reservation in the middle of our state, and we have a navigator who works near there and then travels and goes and attends tribal meetings and works with their health clinic and be able to be a part of that community, essentially. I will tell you that that's had varying degrees of success depending on tribal leadership and what's going on. But, you know, the first year or more, it's like, who are you? And then to be able to say, oh, wait, you're here again. It takes time to build those relationships. And we may not see things come to fruition right away. But that's okay in order to be able to provide the information. And we've been able to get information out throughout the state through building those relationships. Be patient and persistent is my recommendation, and what I keep telling the staff. You aren't going to see things right away, but building those relationships through time is what's really going to help. Another incident I just thought of is we go to prisons and in their transitional services. So as they're leaving, that's a time that there's a lot of instability and unknowns. And so we're a part of that process. We go in and we sit with people that are they're moving from, apologize, but they're moving out of that life into trying to be able to be self-sufficient. And so we are there to support them and help them out. Those are just some ideas as far as going to them continuously is how I would recommend doing that. Thank you. Sounds great. And later, if you're stewing about it and you think about something else, or I said something wonky and you're like, I wonder what she meant about that, again, feel free to reach out. I'd be happy to answer any questions or share ideas. I would like your ideas as well, because I think it is that collaborative idea sharing that we can begin to be better and reach people where they're at. Thank you, everybody.
Okay, thanks, Melissa. Great stuff. Good job. I just want to take a second to thank everybody for attending today. The Just Pull Yourselves Up by the Bootstraps session with Melissa and the AHA process. I just want to let you know that we do offer complimentary webinars on the first and third Thursday of each month. And if you like these presentations, you're going to love and enjoy our addressing the challenges of poverty conference, September 22nd through 24th, 2019 in Indianapolis, Indiana. And we invite you to go and register at ahaprocess.com. And I can tell you personally, there's some great food in Indianapolis. I've been there for that. So thanks everybody again for the wonderful ways that you support individuals in your community. And so until next time, so long everybody.